I'll start sharing my screen. Do let me know if my video stutters or there is some lag or my pace is too fast and all. Just let me know. Okay, I'll share my screen. Yes. Can I have few videos turned on? Mostly I can say is blank. No videos as of now. Can I have a few videos on? And I like to have a very interactive session as much as possible. If possible, you can unmute and speak. If it's too much for you, I understand you must be working somewhere, working at OPDs or might be currently at hospital settings and all. So completely understandable. But at least if it is very difficult for you to turn on the video, please try to at least unmute and speak. And if that is also difficult, please make use of the chat box. Okay. Thank you. Right. So basically, we are going to cover two parts. Okay, communication, basics of communication, and communicating bad news and collusion. That's three parts. And we usually take basics of communication as one session alone. So it itself is 1.5 hour session, and breaking bad news, communicating bad news, and collusion is in itself is 1.5 hours. So these two sessions has been clubbed together. So I understand it's going to be a bit lengthy and a bit long session. I'll try maximum to cover. Also, the PPTs will be shared. So if at all there is any doubt, even after the session is over, please reach out or reach out to our facilitators and other team members. Okay. So the basics of communication, basically, it has the basic skills that we need to communicate properly. I am very sure that you must be knowing all of those skills. You must be already having those skills. I'm just going to refresh you through what are the skills that we have already learned, but somewhere we might have forgotten it, or somewhere because of the busy schedules, busy OPDs, and maybe we are having hundreds and 200 patients daily. Because of that, we might have forgotten it somewhere. So I'm just going to refresh you through what are the basic skills that we need. Forget in palliative care, even otherwise, what are the basic communication skills that we need? That is the first part. Okay. Right. So studies show that just a second. Studies shows that 60% to 70% of the medical errors usually happens as a result of poor communication, which is completely preventable. So why we need communication, the basics of communication as a module is because to avoid these medical errors that we usually see. Active listening. So one first and the foremost skill that we need to attain is active listening. What is active listening? We have here, what is the basic difference between hearing and active listening? For example, I have a few participants who has joined for the session, right? So amongst this, how many of you are actively listening to what I am saying and how many of you are just there? There's a big difference, right? So what is this active listening? Okay, I have around 20 participants who have joined. Maybe from these two or three might be the facilitators and coordinators. Okay, I have maybe around 70 participants. So what is active listening? You can use a chat box, okay? If you can unmute and say it, well and good. So what is active listening? Can I have a few videos on? I would like to communicate or you can unmute and say, what is active listening? How many of participants in my session is like actively listening to what I'm saying? Thank you, Kitana ma'am. Thank you. Thank you for having your video on understanding. Yes, that is one thing. So basically, active listening is hearing is another thing. You can just be physically present somewhere and not listen to what the other person is saying. Okay. Actively listening means you are physically present. Thank you so much, Shantia. Hearing patiently, hearing, we make sure that we listen to the other person, we understand what the other person is saying, and also we, in some way, we respond to the other person. For example, we make in head notes, in one or the other way, we respond to the other person. Also, we clarify, if at all we have any doubts in what the patient is saying, we clarify what the other person has. Thank you, Purnima ma'am. Listening and responding. So that is called as active listening. So active listening is one of the most important skill that any person, especially working in palliative care, you need to have active listening. You need to attain this active listening skill through practice. Okay, right. Moving on, we'll be covering today's basic communication in two levels. Some positive body language that we can attain while we are talking to our patients, and what are some of the verbal do's and don'ts that we need to take some care. Okay, so we have a baby's photo over here. Okay, so what does a baby convey? Can someone say? What can you make out of the baby's face? How is the baby feeling? I'll wait for a few responses. You can use the chat box, okay? Just by looking at the baby, what do you feel the baby is going through? What is the baby feeling? Thank you, Jaydeepa ma'am. Response. Okay, so what does the baby what do you understand from the baby's face? Nothing. Mistake done and not accepting. Okay, I'm caught red-handed. I did something wrong and my mom just picked me up. Mistake then I'm not accepting. Very good. Thank you so much, ma'am. Looks like boring talk. Oh, like yeah, she seems already fed up, right? Thank you, Shantia ma'am. Anything else anyone else would like to contribute? Okay, so maybe the baby over here is hardly 3 years old, maybe, and she already seems fed up with life, right? She's already done with life and everything else about it, right? So, did the baby say something to us? No. So, how were we able to make out of these feelings? Because of the all the other body language that the baby is showing, the baby's face, the baby's body language, how she has kept her shoulders, everything is telling us something about the baby's present condition, right? So, according to Albert Meherbian's model, out of the whole communication that we make, the spoken words is taking only of 7% of the whole communication. The rest of the 38% of the communication is done by the voice and tone, and 55% of the communication is done by the body language. For example, I'm taking this session. Okay. If throughout the session, throughout this 1.5 hour, if I take the whole session in one single tone, for example, newspaper. Okay. So this happened, this and this happened. Like if I go on taking the session in one single tone, you will get bored. None of you are going to listen to me. Okay. So half of the communication, 38% of the communication is done by the voice. I increase my voice, I decrease my voice, I at times pressurize at some time, I make it like, okay, this is mandatory, that I change my tones, right? And also the body language that I use is also very important to keep you engaged, especially when we are taking sessions in person. This is online, so you have a lot of relaxations and all. But if we are having a communication in person, these things are very important. So, of the whole communication that you do, only 7% is actually taking up the words. The spoken words is taking only 7% of the whole communication. The rest of the 38% is taken by the voice that we use, and the 55% is depends upon the body language that you use. Right? So, how can you create a positive body language? That's the next thing that we are going to see. So, what are some of the positive body language that you can learn? The first and foremost thing, the moment you meet someone new, the moment you meet someone, the first form of communication is through eye contact. So, the very first form of communication that you do to a patient is through eye contact. These days, I hardly see patients and doctors making eye contact with a patient. For example, you're sitting at an OPD. Okay, so you're sitting in an OP clinic, and there is this patient who is coming over. What we mostly see is either we check the files, the results, the reports, or we scroll through the phone, or we look into the system, and we check the patient number, serial number, all of those things, the history, everything. But we barely take time to take our eyes off these and look at the person in the eyes. Right? So it is very important that you make a proper eye contact with whoever you are meeting, whether it's a patient, whether it's a senior, whether it's a junior, whoever it is, make sure that you make a proper eye contact with the person you are speaking to. And when you look at them, you do it very slowly. It's not like you're giving a stare. You don't have to stare at someone constantly. Like, just make sure that you look at them. You just lock your eyes and come back to your work. Okay? Don't look down when you look away. See, I completely understand while a person is speaking, it might be very difficult for you to look into the eyes for long hours. So, if you feel like taking a break, you can just maybe blink your eye. Okay, maybe you blink your eye for one or two times, or if even if you want to look somewhere, there is something called as good triangle. You can look at the other points of the face instead of looking at the eyes. Okay, I'll come to that. And also you can rake your gaze to make a gesture or not. You can just, nod with your head. You can just blink your eyes for a second and but make sure that you have proper eye contact while you are speaking to someone. See, this is called as a good triangle. So even if you feel like you don't feel like looking at the eyes, maybe you can look at the cheek parts, or you can look at the chin part or the lip area, so that the person will still feel that you're looking at them. If there's a patient in front of me and I don't look at him, I don't have a very good proper eye contact, I'm just doing my random work, they're not going to feel satisfied. They might feel that, okay, you don't care about them. So the first and foremost thing is you make proper eye contact with the person, whoever is sitting in front of you. And make sure that you smile. Even if you're wearing a mask, make sure that you are smiling. The smile can be seen through your eyes or maybe heard through your voice. So make sure that you smile. And also the tone of voice, how you say matters a lot. Be kind. So whoever is coming to you, they're not here because it's a mandatory thing. They are here because they are in a very vulnerable stage, right? People come to hospitals, people come to meet nurses, people come to meet doctors, not because they are having a very pleasant feeling. They are there because they are in a very vulnerable situation. So make sure that your voice is not very rude. You smile, the voice is very kind. The fact is that even when you smile itself, your voice kind of changes, right? So I'm speaking with a smile on my face, so that itself sets this tone of my voice. If I'm having a very cranky face, I'm not smiling, I'm very rude, my face is very rude, and my face is very cranky, my voice is also going to be cranky. I might sound very rude, very harsh to the other person, right? There are certain doctors, right, who have very serious face, they don't smile, and their tone is also very cranky, right? So don't do that. Make sure that you smile, and the smile itself will set the tone of your voice. Also, there is this picture over here. I would like you to spend some few minutes over this. Which picture amongst the above ones, okay, the right and the left one, is the correct way to communicate with the patient? The right one or the left one? Which is the correct one? And why do you feel so? You can unmute or you can use the chat box. Out of the pictures that are there above, the right and the left, which one do you feel is the right way to talk to a patient?
The left one.
The left one. Which is, it might be different for you, right?
Which is the patient sitting upright.
The patient
And the
is sitting
doctor is
upright, standing. Okay. Okay, I have a few responses in the chat box as well. Thank you, Jaideepa ma'am. Right. Thank you, Kirtana ma'am. Sitting opposite to the patient. Okay. Any other responses? It's okay. Okay. Even if you make mistakes, it is fine. We are here to learn. Even I might learn something from you. It's a two-way process, right? Learning happens in two-way process. Right. Any other responses? Sorry. Right. Okay, so what usually is the right way according to a universal way of communication? If you can look at the left picture, you can see that the patient is a bit strained. Can you take a note of that? He's bending forward, his neck and his head is a bit strained. He has to bend forward to, see the doctor's face, right? He's bending forward, which might cause tension towards his spine area and all, right? So his neck area and his spine area, his head area, everything is kind of in a strained position. So what we usually suggest is, as some of you have already said, sitting beside the patient. That is the most apt way of communicating, because here you can see that the patient is relaxed. The patient is relaxed. The patient, the body leveling is correct. It doesn't give off the idea that the doctor is of someone higher authority. I have more power over you. It's nothing like that. The doctor and the patient, they are both at same level. There is equality there. So there is higher satisfaction from the patient side. Also, the patient is completely relaxed, no strain over anywhere on his body. So this is what we usually suggest. And I completely understand it may not be possible for us to have so much space in our ward, right? It is not possible for us to, have so much space in our ward so that we can put chairs and sit. If at all you have to stand, I would suggest you to stand at the foot end of the hospital bed. Does it make sense? So that again, the patient is relaxed. The patient doesn't have to bend forward. Even if you're standing and speaking, make sure that you're standing at the foot end of the hospital bed while you're having a conversation, so that the patient can see you. Eye leveling is again correct, right? If I'm standing at the foot end, my eye leveling is correct with the patient, right? My eye leveling is correct, my body leveling is okay. So the patient doesn't feel like, the patient doesn't have to strain much. So always take a note of it, that if ever you are standing by the side and having communication, not to check any, not to do any physical examinations, okay? If you have having a conversation with the patient, make sure that you're standing at the foot end, so that at least make sure that the patient is relaxed. At nowhere the patient has to feel strained. The patient doesn't, make sure that the patient doesn't bend forward or strain his neck or spine area. Okay, at least make sure that that can be done. The right way is always to sit beside the patient and speak. Okay, and usually this is the third picture, where which the doctor is sitting at the knee level. It is usually followed at Western Indias. I have not seen doctors following that here. So when you are speaking to a pediatric child, what we usually see is that sometimes we bend over and speak, right? So we bend over to the child and speak, which is not very comfortable for either of the child or the doctor or the nurse. So what we suggest is, again, make sure that you're sitting beside the child and having a conversation, so that the child and you have the same body level, same height, there is equality, the eye level is correct, right? The eye level is proper, and speak. Or else you can bend on the knee level. I don't usually see that in Indian scenarios, but that is what usually followed in Western countries now. Does it make sense? Any questions, any queries, you can use the chat box. You can always unmute and ask. Thank you so much for the responses. Moving forward, the next thing is body posture. I have never seen any doctors, any nurses being in the first, as in the first picture. Okay, I have never seen in India, especially, I have not seen anyone do like that. Okay, never have a very relaxed body posture. Okay, it's as if I'm having a very relaxed time. Okay, there is this patient who has come to my OP. I cannot just go back and relax and sit like that and go through my phone and all. That would be very disrespectful for whoever is coming in front of you, right? Make sure that you are bending forward. Your body is slightly bent towards forward. It shows that you are interested in what the other person has to say. You have genuine interest to listen to the other person. So make sure that you bend forward while you're having a conversation with a patient. Okay. So always have a body posture that shows that you are bending or leaning forward, so that it means so that the other person gets this idea that you have interest in what the other person has to say. Never take a very relaxed posture. I can just relax back on my chair. Nothing like that. Okay. Bend forward body posture is showing that you are willing to listen. Here, the patient satisfaction is much higher. The next is leaning forward. See, also at times you can mirror the posture the other person is doing. Okay, like if the patient is also coming forward, you can slightly bend forward. And if the patient is slightly moving backward, you can slightly move backward. Don't lean back and relax. Slightly you can move backwards. That is called as mirroring. That also makes the other person likable. Okay, the last one is respecting body space. So our body space is basically divided into four areas. Okay, so we have the intimate space and then we have our personal space. Intimate space means those which we only our spouses, maybe the intimate space we only allow our spouses, our husbands or our partners or our wives to be inside, or maybe our parents. I don't think we even let our parents into that space after certain age. But yeah, to an extent, we can let our parents, for example, especially our mothers, we let our mothers into that intimate space. And then we have a personal space where we let our close friends, our family members to be in. And then we have a social space where we have a workplace, where we have our colleagues, etc. And then we have the public space. For example, we are waiting for a bus. You're standing on a bus stand. That is called as a public space because there might be people who are completely strange to you. So this is called as a public space. So if we divide our body space, we have intimate space, we have personal space, and then we have social and public spaces. Being a nurse or being a doctor or being a health worker, we mostly what we do is we have to get into the intimate space of the other person, right? Because the patient needs that care, because it is needed at that point, we tend to invade their intimate space. Although there is implied consent, even though there is implied consent, we don't directly take consent. We assume that we can get into their intimate space, right? So we tend to move into their intimate space. What do you think? How else can we do it? What I would suggest is, for example, we need to change catheter. Okay, we need to either insert a catheter or we need to change a catheter or we need to remove a tracheostomy or we need to insert a tracheostomy, whatever it is. Okay, we are invading their personal, their intimate space, right? Do we ever take consent from them? Do we ever take consent from them? Or do we assume that the consent is there? For example, there is this patient over there. He's 56 years old. He had a stroke or he had RTA, road traffic accident, anything. And he has he's completely paralyzed. He cannot respond. He's not conscious. Okay. So you need to change the catheter. What do? We randomly go and change the catheter, right? We remove the catheter, we insert the catheter. Have we ever thought of taking consent? We know that there won't be any responses from him. We know that he's not in a position to respond to what we are asking, but make sure that you take consent. Whether he's responding or not is not our question. That there is a human being who's in this position, not because he wanted to, right? If he's conscious, if he's actively moving, he wouldn't want you to, inserting catheter and removing catheter and all. Now he's in a very vulnerable situation. So make sure, even though he's not responding, even though he's not conscious, just make sure that you tell them, see, I'm going to remove the catheter. This is going to cause you some discomfort. How much time will it take? What if he can listen to it? What if he's aware of it? We never know, right? So make sure that you just mention that, see, Acha, I'm going to remove the catheter. This might cause you some discomfort and then remove. Same while inserting the catheter as well. See, this is going to cause you some discomfort. I'm going to insert the catheter. Even if he is not conscious, even if he cannot respond to what you're saying, make sure that you convey this, right? See, there is this human being who has been working for a while, who was independent. Now the patient is in a critical or vulnerable situation. Doesn't mean that we can take the concern away from the person, right? Does it make sense? Make sure that you take consent or at least inform the person that what you are going to do. This actually is respecting their body space, right? So as strangers, we invade their space. We believe that there is some implied consent, but if you at least inform them about the discomfort, inform them prior that there is going to be some discomfort that is going to be there while I'm inserting this catheter, this might actually change a lot. It might increase their dignity. It is actually respecting other person's body space. Okay. So always have this in your mind. So, yeah, there is this two pictures over here. What differences do you see in these two pictures? Any difference? How is the patient in picture that is there in the left side? Is the patient very comfortable? Does the patient seem pleasant and comfortable? No. Thank you, ma'am. No, the making patient uncomfortable or scared. No, thank you, Abhishek sir. Thank you. Right. If you look at this first picture, you can see that there is some the doctor's face. You can clearly see that he's showing he is very authoritative. He is having some power over the patient, right? And the patient seems. Thank you, Gemini ma'am. The patient seems threatened. The patient is scared. The patient has moved backward because the patient feels that he's invading the space. The doctor is invading into his personal space. But when you look at the second picture, there is body level is correct, eye level is correct, eye contact level is correct. There is mutual respect there. The patient is very comfortable. The patient is having a slight smile, right? There is smile on the health workers' face as well, right? So make sure that you never invade their space. You don't have the body language, body cues in which it scares the patient in front of you, right? So make sure that your body level, eye level is correct. You have a very small smile on your face. Obviously, it depends upon the cases. If you're dealing with a very serious case, you cannot smile. But if you're meeting someone, a new patient, you're registering a new patient, make sure that you have a small smile, the body level, the eye level. Always be cautious of these points. Okay. Right. And the last portion is touch is very important, very therapeutic, and it can create magic, I would say. For example, after COVID and all, we have stopped, touching patients and all because of the scare that is behind all those diseases and all. But it is okay even if you sanitize in front of him. It is okay even if you have to wash your hands after that. But make sure that if there is a need be, looking at the cultural context, okay, you cannot go randomly and touch someone. It has to be gender specific. It has to be culture specific. There has to be that space between the patient as well as the health worker, right? So touch is very important. How I use touch is that when I'm having a conversation, when I'm communicating bad news to a patient, when I'm having a counseling session or I'm communicating bad news to a patient, their eyes starts welling up. But they won't cry. They will just hold their tears back. They won't cry. They'll just try to hold their tears back. That's when I just slightly touch their hands or pat on their shoulders and they start crying like anything. They just feel so comfortable in that. That's the point where they start venting out. That's the point where they start crying it out, right? So touch is very important. If you come to our rounds at Palliative and all, you can always see, our doctors either say, it's okay, it's going to be better, we'll touch at their hands or at the shoulder levels and all, some form of touch. Only if it is necessary. Gender, you have to be very careful of the gender and culture, etc. But it is very therapeutic. It is having a therapeutic nature to it when you touch your patients, especially when you are in palliative care. Right. So, what are some of the verbal do's and don'ts? Never ask leading questions. For example, there is this patient who had breathlessness yesterday and you gave some medicines, and today you are going for rounds and you saw that patient and you cannot ask, your breathlessness is better, right? Isn't it? Your breathlessness is better, right? Never ask. Even if the patient is having some difficulty, he might be forced to say he is feeling better, right? Instead, ask, how are you today? How is your breathlessness today? How are you today? How are you feeling today? Right? So never ask leading questions. You're better, right? You're feeling better, right? Isn't it? Never ask leading questions. The patient might be forced to say, okay, anyway, the nurse is saying that I am feeling better, right? So I might have to answer it like, okay, I feel better. The patient might be forced to say that the patient is feeling better. So instead, ask, how are you today? Always ask open-ended question. Don't minimize, don't compare patient's problem. For example, if a patient has come to you with a toothache, okay, just a toothache, a normal dental care that is needed. Can I say that, oh no, I'm working in palliative care. I have seen so much pain. There are people with CEA, though, that and this, and stage 4 and all. I have seen so much pain. Why are you crying over a toothache? Can I say like that? No. Because for this person who is in front of me, the tooth is going to be the biggest pain that he is having, right? So never minimize, don't get so worried over small things. Never ever minimize the problems that our patients bring on table, right? So never say that there are so many people. I have worked at RCC Regional Cancer Center. I have seen pediatric patients. I have seen kids suffering. I have seen that pain. Now you're so much. You are a 65-year-old. Now why are you crying so much? I cannot say that. I cannot compare. I cannot say that, even I had to go through such emotion. I lost my mom at this age and all. Why are you crying? It's been almost 1 month. Why are you still crying? I cannot compare. I cannot do that. So never compare because it is very subjective. The pain is very subjective. If I have 17 participants in this session, the 17 of you are going to feel pain in different ways. It's not going to be a similar way, right? So never compare, never minimize. They will feel you don't care, right? So how we can otherwise say is that anybody in your position would perhaps feel the same. Maybe this is beyond what I can imagine. It might be more than what I cannot even say that I understand your problem. Can we understand a person who has come to you with CA pancreas? Have you seen CA pancreas cases? The pain is so terrible. They can barely bear. I have had a case where the lady used to crawl on floor because of pain. Can I go to her and say, I understand your pain? How can I understand her pain? We cannot say I understand your pain. We cannot say, there are much more problems. I have suffered so much. Don't do this. Never say. I can only imagine what you're going through. See, I can only imagine how can we otherwise know what they're going through, right? I can only imagine what you're going through, right? Considering what you're going through, it is normal, it's normal to feel, it's normal to cry, it's okay. It acknowledge what they're going through, right? Don't give false hope. Don't worry. We are with you. Our hospital can do this and this. We will take care of all your problems. Never give false hope. We had this patient at Palliative who was 22 years old. After having road accident, he became paraplegic. But the doctor who treated him said that he might walk after 6 months. He was in this idea that he's going to walk after 6 months, not aware that he's going to be wheelchair bound for his entire life. He is just 22 years old, 23 years old. So can I go and say, it is going to be all right? No, whatever you have to say, you have to be very factual. I will be coming to it when I'm discussing collusion and communicating values. Okay. Do give realistic hope. Your disease may be progressive. So I'll do my best to keep you comfortable as long as it's needed. See, there is no curative aspect, but I'll try to do symptomatic management. I'll try the symptomatic management that can be. I can make sure that you're comfortable. I don't. I may not be able to completely cure, but I can maybe able to keep you more comfortable. So always give realistic hopes. Do not assume. Do not assume their pain is okay and all. You have to ask them. Okay, always ask them how they are, what they are feeling. Right? Don't use jargons. Don't use medical terms and all. Okay, say this is CEA pancreas with multiple metastasis, this and that, and don't use jargons while speaking to common. Speak in common people's language. Make sure that they understand what you're saying. Do not be patronizing and I'm really sad that this happened to you. Don't do that. This is going to hurt them. Do not moralize, do not philosophize. See, if there is life, there is going to be death. There is this right and wrong and all. See, don't speak these things to people who are suffering. This is going to only make things worse. Avoid inappropriate humor. See, we tend to use humor because we cannot say the truth, right? Don't do that. This is again going to hurt them. This is just a history taking, how you can use all the skills that I have said in a history taking. Okay. So a patient is coming over to you. The nurse has to register the patient, right? So make sure that you make proper eye contact with the patient. You make an eye contact, you smile or no, say hello, good morning, namaste, namaskaram, whatever it is in your local language, in your regional language. Right? Give a comfortable seat, offer a seat in OPD, sit down by the bedside. If it's IP ward, rounds, or anything, make sure that you sit down or stand at the foot end. Or if it's OP, make sure that you give them a seat. Start the interview with an open-ended question. How may I help you? What brings you here today? What brings you to OPD clinic? What brings you to our clinic? Right? How are you today? If it's an IP patient, you can just ask, how are you today? How are you feeling today? Listen, do not interrupt. Let them say their story. I went to this doctor. The doctor said that I had some pain. From there, I was asked to take MRI or biopsy or whatever it is. I have come with the result or whatever it is. They will start telling their story. Let them speak. Make sure that you maintain your eye contact, nod your head, make encouraging sounds. Go on. Clarify. If at all there is something that you did not understand, make sure that you clarify. I did not understand. Can you please repeat what you said? Ask about what they understand about this. See, most of the time the patient might know that the patient is in stage 4 cancer, but they don't understand what stage 4 means, what the consequences are, right? So make sure that you understand how much they understand about their situation. What did the doctor there tell you? Do you know what the report says? Do you have an understanding of what the report says? Do you know what an idea of how you are, what is about to happen and all? Ask about their concerns. What are your major concerns and what is bothering you as of now? Is there pain? Is it something else? What is your major concern? Share information, be very honest, be factual, don't minimize the severity, don't just say that this is going to be fine, our hospital might take care of everything. Never. Be very honest, be factual, simple language, no jargon. We might deal with emotion, they might cry, they might throw tantrums and all. Do not give a menu of options to choose from. Discuss pros and cons. What we can do at this point is symptomatic medicine. We don't have any curative aspects at Pallium. For example, at Pallium, what we are looking at is comfort care. So this is what we can give you. We don't have ICUs, critical care, or anything like that. But what we focus on is comfort. So what? See, this is what, if at all if the patient is wanting curative treatment, you can say the pros and cons, whatever it is. Discuss pros and cons of options. Recommend a line of treatment. You're more than a prescription vending machine. You're not just there to prescribe some medicine or, just to see some patients and go off, right? Listen to their beliefs, fears, problems, constraints. Even if we give them the best suggestion, it's not necessary that they take up. See, even if we give them the best options available, it is not necessary that they have to cater to. They won't take the suggestion unless they believe. For example, even after explaining all this treatment, maybe we say that only comfort care is there. There are patients who says that, okay, I'll just go and take Ayurvedic treatment. I'll take homeopathic treatment. So it is not necessary that they completely listen to what we are saying, but it is our duty to explain the pros and cons, what we can offer. Right? Participatory decision, we cannot force someone to be in this treatment, right? It is always the patient's and the family's wishes and desires at the end of the day. But you make sure that you tell your treatment options, summarize the interview, confirm the treatment plan or the next visit. Before closing the interview, is there anything else you want to ask or say? Is there anything else you would like to clarify? Is there anything else you want to ask me or say? Close the interview, leaving the door open. In any case, you need to contact me or my team, you can call at this given number at this time. We will be available during this time period. Greeting again, make eye contact, smile, nod your head, say goodbye, namaste. That's it. That's how you end the interview, and that's the whole thing about talking about the history taking. Empathy as an experience depends on how we behave with our patients. See, patients and families remember how they are made to feel and not how they felt, right? So that's what they remember. So always make sure that you treat them in a way that they remember how they were made to feel, right? Talk less, one mouth, we have one mouth and we have 2 ears, right? So talk less and listen more. Practice body language, positive body language, and remember the verbal do's and do's. With this, I come to the end of the first session. Any doubts, queries before we move into the second session, which I might need actually 45 minutes? Any doubts, queries? Was I too fast? Was my pace okay? Am I being too fast? Any inputs? Thank you, Anugraha ma'am. Thank you, Anugraha ma'am. Thank you. Right. So we move on to the next topic, which is communicating bad news. This is going to take some time. So because this is the whole topic that we need to keep in mind how to communicate bad news. So there is this patient who has come to you with certain reports saying that the patient is having CEO ovary and there is already metastasis and maybe there is no curative aspect possible. How are you going to deal with this? How are you going to communicate this news to the patient? That is the whole point of communicating bad news. Okay, I'll take this in two portions. First one will be communicating bad news, and the second one will be collusion part. Okay, we already looked at the skills required for communication. Why do we need communication? It enhances the therapeutic nature of the medical encounter, reduces uncertainty, and improves outcomes of care. For example, when we communicate properly, what happens is that so we had this patient who is, I think, who is 28-year-old. Her mother had cancer. Her aunt had cancer. Both of them took treatment, and still, after even after taking treatment, they passed away. So this girl was in this idea that even if I take treatment, I'm going to die. So why should I take? But her case was completely different. She had a curative management was possible on her case, but she was in this idea that okay, I won't take treatment because anyway I'm going to die. So in order to reduce such uncertainties, also we need to communicate properly. Also, it improves patient satisfaction. Also, to prevent inappropriate hope and guilt. For example, as I said in the previous session, there was this boy who was told that he will walk again after 6 months because the doctor is for some reason he felt it he felt discomforting actually communicating to the boy that he won't walk or he is going to be wheelchair bound. So this boy was in this idea that unless I am able to walk again, I won't work, I won't do anything. I'll just be at home. I'll do exercise, but I'll just be at home. He was not in the process of accepting the fact that he is going to be wheelchair bound, right? He was not thinking of any other possibilities of having a job, for example, setting up a petty shop or doing some lottery work and all. So he was not thinking of any other possibilities because he was in this idea that he's anyway going to work after 6 months, right? So in order to prevent inappropriate hope and guilt, also it is very important we communicate properly. Also, to prevent conspiracy of silence, we might again come back to. Have you ever heard of this term conspiracy of silence? Conspiracy of silence. Conspiracy of silence, it means that everybody in the room knows what is going to happen, but nobody is willing to come out and say it loudly. For example, we had this CA 35-year-old. He had CA lungs. He had multiple metastasis. He was deteriorating, and for sure that his days were counted. Okay. He had two young baby kids. I think that they both of them were kids. Yeah. I think 5 and 3 years old. That was the age of the kids that he had, and his wife was around 30s. Okay. So there was this wife who we had to communicate bad news, but she did not allow us to communicate this towards the husband. She said that, please don't tell my husband regarding this. So she knew the truth, but she was not willing to say it loudly. She was suffering alone. So when I had a session with the husband, with our patient who was 35-year-old, he already knew that his days are counted. He had an idea that, okay, I know that I may not survive. But you know what he'd ask me? Please don't discuss this with my wife because she may not be able to take the truth. So here, the husband was kind of protecting the wife, and the wife was protecting the husband, but both of them knew the truth, and they both were suffering alone. This is called as conspiracy of silence. Everybody knows what is happening, what is about to happen, but nobody is willing, because they feel that if I tell this loudly, what if the other person starts crying? So I'll just hold this information, I'll just keep it for myself and I'll suffer alone. I am keeping this information, I'm suffering alone. I can't cry in front of my husband because if I cry in front of my husband, this might hurt him, right? This is called as conspiracy of silence. And in this, the patient as well as the caregivers, both of them suffer a lot, and most of them, they're alone in this. So what we're trying to do is we are trying to prevent this conspiracy of silence and bring them together in suffering. We need to have the husband and the wife or the kids, whoever is involved, we need to bring the family, the people involved together in this suffering so that, they feel some kind of support system that is there. This is called as conspiracy of silence. So in order to prevent conspiracy of silence also, this is communication. Medical communication is very important. Right. So impact of communication. If done properly, it can lead to a range of negative emotions like shock, disbelief, numbness, guilt, etc. And if it is done in a very well manner, it can lead to a stronger and trusting relationship that can help in better patient care. I'll explain this with an example. Okay, we had this patient, okay, pediatric patient, which was referred to us from a pediatric medical college that is there in Trivandrum. It is called as SAT. It is a government pediatric medical college that we have in Trivandrum. We had this child with a very rare disease. The disease was called as Menkes kinky hair disease. So child is born copper deficient. The child is born copper deficient, and a child with Menkes kinky hair disease won't go beyond 1.5 years of age. The death is sure. We also know for sure that the child won't go beyond 1.5 or 2 years of age. But the way it was communicated to the mother, if you ask her, she still remembers, she still hates the doctor who communicated the news to her because of the way in which she was communicated. A very prominent doctor of a very prominent department of government medical college in Trivandrum, just randomly. This was her first child, the only child that she had as of now. She was already 30 years old. So the only child that she had, and this doctor came here and said, I think this was the words that meant. See, why are you for the child? The child is going to die anyway. This was what the doctor had said. So the way in which communications are done is also very important. Till this day, I think this happened in 2021, 2022. Till today, it's already been 2026. Till this day, she still hates the doctor who communicated that. So the way in which it is going to it is going to shatter us. For example, to a lady who has been very independent, who has worked till 56 years of age, suddenly you are going to her and saying that you have cancer. There is nothing much that we can do. This is going to shatter me. This news is going to shatter me completely, right? So the way in which it is also very important, right? Moving on. So I usually do this in my on-site training sessions where I, practice with the nurses or doctors whoever is I'm taking the session. There is this patient who has come to you and say, okay, nurse, ma'am, I don't feel too good. Immediately, the doctor or the nurse is saying that, see, you have not followed my instructions. Maybe that's why you're not feeling good. How will the patient feel? Will the patient feel like talking anything more? No, because here immediately the doctor is dismissing of the patient's emotions. See, the patient is, with some hope he is coming and telling to you, I don't feel good. Immediately, whoever is in charge, it could be a nurse, it could be a doctor, it could be anyone. See, you might not have taken followed my instruction. Maybe that's why you're feeling. Never say that. See, how can you approach? I can see that. Tell me what is troubling you. You're not feeling good. Tell me what is troubling you. This is an open question, may allow easy venting out. Another thing, a patient is coming to you, maybe you're doing a home care, and the patient is saying, see, I'm not able to sleep at nights. It's been 4 days since I slept. I am immediately saying it must be due to the fact that you're sleeping during the daytime. Maybe due to the fact that you're sleeping during the daytime, you're not able to sleep at night. Or just take some diazepam tabs. You should sleep well. Immediately, I'm just giving some medicines. What if the reason for sleepless nights may be much more serious? What if it is much more serious? What if the person is having anxiety? What if the patient is having some depression symptoms? What if the patient is having death anxiety? What if it is altogether something else? How can we know unless we ask, right? So instead of dismissing of the concerns of the patient, what we can say is, I understand. See, it must be very frustrating not being able to sleep, right? What has been troubling you, or what are you thinking when awake, right? What is it that you're thinking of when you're awake? What is it that you keep thinking of? Or maybe the person might be sleeping during the daytime, but only after all the other questions come to the point, do you usually sleep during the daytime? How is your day? How does your day look like? You can ask like that. If we feel the patient is sleeping during the daytime, maybe you can do alteration. But I cannot randomly dismiss off by saying maybe you're sleeping during the daytime. That's why you're not sleeping during the night. I can say that, right? So this is a basic difference between good communication and how we can make it appropriate, more appropriate. Coming to our topic, communicating bad news or breaking bad news. We don't use the term breaking bad news these days because that word itself is very traumatizing. So we use a term communicating bad news. Any information which adversely and seriously affects an individual's view of his or her life, her future. This piece of information that we have is completely going to change the mindset of the person who is sitting in front of you. I am going to say to this patient, the person who is sitting in front of me, that you are having stage 4 cancer. The entire outlook, the entire mindset of the person who is sitting in front of me is going to change, right? So, any piece of information which adversely or seriously affects an individual's view of his or life, how to communicate that, right? That is called as communicating bad news. We have a small activity next. You can see two pictures over here. We have one at the left side and one at the right side. What is the basic difference between these two pictures? Anyone would like to unmute and speak? Or you can also use the chat box. What's the basic difference between the first picture and the second picture? A few responses. Unplanned and planned. Thank you, Jadipa ma'am. One seems more planned and the other seems unplanned, right? Any other inputs? How while we look at this picture, what's like from a very common point, stepwise, okay. Severity of damage is different. Thank you. Mature way of handling without damage. Thank you so much, Anuratha ma'am. Thank you so much, Jadipa ma'am. So if you look at the two two eggs that we have. One, the first egg, if you look at it, the left side one, it is all kind of messed up, right? There are multiple cracks. The white egg white and yolk is completely mixed up, and there is a complete mess over the first picture. And if you look at this second picture, the egg is in correct half, right? Perfect halves, and the yolk and the egg white is separate. No mess is there, completely different, right? This is similar to what I think already most of you have pointed out the points. Communicating bad news or breaking bad news is very similar to breaking an egg. If it is not done properly, if it is not done stepwise, if it is not done in a very planned way, with the skills that requires it, you are liable to make a big mess, and you are going to make a big mess of people's life, right? So we have the power to either ruin a person, completely shatter a person, or we have hold them together, have be a support system for them, right? So that's where the importance of this comes to. We don't have time for role play. I'll just go through it. I usually do this on my on-site sessions. You are a GP, you have seen a patient about a week back for mouth ulcer, not responded to your treatment. You advised him to go to a surgeon who then did a biopsy. Patient has come to you with a biopsy report which reveals that the patient is having cancer. How are you going to communicate to the person, to the patient, that you are having cancer? Usually, I do this as a role play. Because of time constraints, I'm just skipping this part for now. How will you discuss? I can disclose randomly by saying that, okay, you have cancer, get admitted, and let's see if treatment is feasible. The patient is shattered completely, right? Or else maybe I can say that, see, you have been diagnosed with cancer. Perhaps it's all been advanced, and I guess we don't have much treatment possible. I'm afraid you have only 3 months to live. Can I say like that? How is the patient going to feel? You won't believe, we had a patient at Palliative, I think back in 2020, 2025, during January last year, this time, around this time, because January, we had this patient well referred from RCC, Regional Cancer Center. You know what? He was like 56, 57 and all. So he came, I had counseling sessions with him. You know what he said? The doctor from RCC said that, he only has 3 more months to live. Actually, there was this doctor who spoke to this patient saying that, you only have 3 more months to live. And it's almost been about, I think it's almost been, while he came to Palin, it's been almost a year. See, his condition was deteriorating. His condition was progressive. He had multiple meds. So the chances was very low. But we cannot be very accurate of the months, right? We can say that your condition is progressive. We can say that your condition is deteriorating. But are we in a position to correctly quantify the number of days a patient can live? Do we have that insight? Can we actually predict that? Maybe we can say your condition, we had this patient, after even having multiple communicating bad news, she survived for another 6 months. We thought that she might pass away in a week. So, but we never say that, okay, you're going to live only for one week. We we repeatedly say that your condition is deteriorating, your condition is progressive. So we prepare the family. That's how we should do. I cannot go and tell to a patient, you will live only for one week. We know the stages, right? Once the patient starts, there is this breathing trouble, or gas, whatever the stages are. So we cannot be very specific when it comes to dates, can we? I don't think we can make sure that the family is ready. We can make sure that the patient is also ready, but we cannot be very specific about the number of days the patient is going to live, right? So he actually said, I have been almost 1 year since I came. I have been taking. He's continuously taking comfort. Okay, he did pass away. He did die. I think it was last year February or something. He did pass away. Him that he will live only for 3 months. So never be very specific. This is going to completely shatter the person who is rented mental health. Correct. So why is it difficult for us to communicate bad news? One thing is environmental barriers, and then we have the barriers from patients and family side, and then we have barriers from the professional side. So when it comes to environmental barriers, what happens is that we may not have enough time to spend with each patient, right? Because we may not have enough space, we may not have enough privacy. In an OPD, there might be hundreds and 200s of patients who are waiting, so we may not have adequate time to sit and communicate bad news properly to a patient, right? We'll just randomly say, okay, you have cancer, you have to take this treatment, and just we give some medicines and off. That's it. So we may not have space, we may not have privacy. There is this tiny room for us. There is this doctor, there is there, the nurse is there, the social worker may be there, the patient might be there, the caregivers might be there. So you don't have the proper privacy for you to sit and speak. You don't have the time. There might be external interferences. For example, calls might be there, emergency calls might be there, there might be noise outside, right? And the medium also might be a barrier. You may not know the regional language that the patient is having. So these are the environmental barriers. So what are the barriers from the patients or the family side? The patients feel that the doctor is too busy. I don't know how to ask about my condition. The doctor is too busy. How can I go and clarify what my condition is? And most of the time, the patient, they fear your answer. They fear what you are going to say. What if the doctor or the nurse say that I have cancer? What if the nurse say that, okay, my condition is deteriorating? Will I be able to cope with the answer? No. So I fear the answer, so I won't ask. They fear the answer, what you're going to say. And they feel doctor is more interested in the physical care and do not want to know about the emotional problems. Okay, as nurses also, as doctors also, we are more, they feel like you are more interested in physical care. We check the pain, we ask about their pain, we ask about their BP, sugar, bowel movements, everything, but we never ask beyond these physical issues, right? So they feel the doctor is more interested in the physical care. So I do not want to know about their emotional problems. So I won't ask anything. Frightened of breaking down in front of us, because most of the time, if the doctor or the nurse say I have cancer, what if I cry in front of them? What if I cry uncontrollably? Will I be able to manage my emotions? So they are frightened of breaking down in front of us. So what will they do? They won't ask anything at all. So these are the barriers from the patient side. Okay, if I demand more clarification, if the patient demands more clarification, what if the doctors stop treating me? They have this fear. If I keep on asking, we do have patients who keeps on asking doubts, right? If I keep on asking doubts, what if they suddenly come stop treating me? So all of these acts as barriers from the patient side. Why is it difficult for us? Why is it difficult for professionals to communicate? Why is it difficult for the doctors? Why is it difficult for the nurses to communicate? Because most of the time, what we fear is we fear getting blamed. And it has happened in, especially in Indian scenarios, it has happened that, either they blame the doctor, they blame the nurse, they might blame the hospital. It is because of this doctor that this happened to my mother. It is because of this hospital that this has happened, right? So, why is it difficult for the professionals is that we fear getting blamed for the patient's condition. And also, we fear letting the patient down. See, I'm so helpless. I cannot help the patient. How can I not help my patient? This actually keeps us low, keeps us from actually saying what the patient is currently in, what stage the patient is currently in. What if the patient asks difficult questions? Will I be able to answer? So I'll just leave it there. I won't ask anything. I won't say anything. What if the patient starts crying in front of me? Will I be able to manage it? I don't know what to do if the patient starts crying or the family starts crying. So I won't say anything. It's better I don't talk anything at all. Right? What if the patient or the family members gets angry? How will I manage that? Right? Wanting to protect the patient, how do I reveal a bad diagnosis to a patient? At times there are also people who doesn't want to be the carriers of bad messages. I don't want to be the one, with the bad message, carrying the bad message. I don't want to reveal a bad diagnosis. There are people, these fears keep us from actually communicating properly. We may not have enough time. That is a common thing that is going to be there. Also, at times we assume that the family doesn't want me to reveal to the patient, right? So these are the barriers from the professional side, from the doctors and nurses side. So what do we do? Instead of actually having a communication, we take up distancing technique. We won't give proper eye contact. We make sure that we are always busy. We'll only look at the physical symptoms. We never ask beyond that. Sometimes we even categorize by saying that the patient is very difficult. So these are the distancing technique that we take upon because we want to avoid the conversation. So I'm just skipping those points because of the time constraints, right? You can just read on. Okay. When I share the slides, if at all there is any doubts, you can always reach out. So why is it important to communicate bad news? Importance of learning to communicate bad news, to maintain trust, to prevent inappropriate hope and guilt, to allow appropriate adjustment, to prevent conspiracy of silence. How to start? How to communicate bad news? This is a basic, the most important area of this session. How to communicate bad news. First step is getting started. Plan what you will say. Ask appropriate questions. See, what I'm going to say. Make sure that you have proper atmosphere, environment for that. You have adequate time, adequate privacy. You have proper environment to communicate bad news. And make sure and plan whom to involve. Should I tell to the patient first? Should I involve the children first, or should I involve the parents first? Right? Should I involve the partner, husband, or wife first? Who am I going to involve in this conversation? So planning takes part in the step one. Planning takes part in step one, getting started. Plan what will you say. Make sure that you have adequate time and environment for that, and determine whom to involve in the conversation. Next step is how much the patient knows. Have an insight into what the patient already knows about his condition. See, it's not necessary that they might know. Sometimes they might already have an idea. Sometimes they might have Googled it. Sometimes they might ask ChatGPT. Sometimes they might have read the report, right? So they might have some idea. So you have to know how much the patient already knows about his or her condition. So, so start by how it all started. But start by an open-ended question. How it all started, right? For example, the patient might say, I had a patient who was 23-year-old with osteosarcoma. So her case was like, okay, if I ask her how it all started, she would start by saying, I had a small back pain, and after having the back pain, I went to a local doctor. The doctor gave me vitamin D tablets. After taking the tablets, also my back pain did not come down. After that, the doctor asked me to do a biopsy, a MRI, and that's how it all started. The patient will start narrating the whole story. Only then you will be able to how much the patient already knows and how much the patient is willing to know more. Okay. So the second step is insight into what the patient already knows. Perception of what the patient already knows. How much the patient already knows, the perception part. And the step is how much the patient wants to know. See, it's not necessary that the patient wants to know about his prognosis or deteriorating condition, right? There are patients who says that, I don't want to know. So how are you going to approach it? After knowing how much the patient knows, ask. See, I would like to say something regarding that, but what I'm going to say is not something that is very pleasant to hear. It might be very difficult for you to understand. It might be very difficult for you. It might cause a bit discomfort in you. You already gave a warning shot saying that what you're going to say is not a very good news. This is called as warning shot. Warning shot is very important. Okay. Do you still want to know? After giving the warning shot, I invite the patient. Do you still want to know? Here, the patient has every right to say yes or no. Does it make sense? Am I clear? Any doubts, queries? Please use the chat box, okay? So, in the third step, what you do is you invite the patient. You give a warning shot. You already say, whatever I'm going to say is not something that is pleasant. It might hurt you. Do you still want to know? If the patient says yes, we move on to the next step. That is where the actual sharing of information takes place. You are very honest, you're very factual, you're not minimizing the severity or anything. Say, then stop. Be very kind, be very slow, and make sure that patient has understood what you're saying. The patient might cry, the patient might vent out. Pay attention to emotions, be clear, be gentle, be very slow. Don't minimize the severity. Fifth, responding to feelings. Effective responses. The patient might cry. The patient might throw tantrums. The patient might be showing anger outbursts. The patient might have a lot of cognitive responses, a lot of doubts. There might be basic psychophysiologic responses. The patient might start shivering, whatever it is. Give time to react, listen, be there with them. A lot of nonverbal communication. Pat them, just hold their hands. They might cry. Give time for them to respond. And the last is planning and follow up. Plan for the next step. What can be done next? So, what is your focus? So, we are focusing on comfort care, or our hospital is focusing on comfort care. So, these are the things that we can do. We can do symptomatic management. So, plan for the next step. Discuss potential sources of support. Give contact information for them to reach out. This is called as the spikes protocol, which is universally accepted protocol for communicating bad news. First step is setting up, right? Where we set the environment, make sure that what we are going to say, we plan what to say, we plan whom to involve. Second step is perception. We First, we get to know how much the patient already knows about his condition. The third step is invitation, which is called as we give a warning shot and we invite the patient. Do you still want to know? And the fourth is knowledge, where we actually give the facts. The actual information is passed. And the fifth one is emotions. We address their emotions. They might cry, they might show anger outbursts, whatever it is. We give time for them to vent out. And the last is strategy and summary. How are you going to move ahead? This is called as the spikes protocol. Any doubt in this area? Any doubt with spikes protocol? See, I'll say a few scenarios that might arise. Okay. Especially when it comes to spikes protocol, in Western countries and all, it is completely okay to directly go to a patient and communicate bad news. Okay. But when it comes to Indian scenario, what happens is that if we go to a patient and directly communicate a bad news, and if the patient collapses, if the patient faints or collapses or something bad happens to the patient, the entire family is going to burn down the hospital. They might blame you, they might blame the doctor, right? It's the usual scenario that we might see in and around India. So what we usually suggest is communicate bad news to the caregivers first. Okay, and then take caregivers' consent. See, this is the conditions. I would like the patient also to know about it. I would like your husband also to know about it. Can you give me, take consent? If they give consent, talk to the patient. But there are going to be scenarios where the caregivers won't give you consent. The caregivers would say, please don't say to Amma, my Amma is anyway going to die. Please don't tell her that she's having cancer and she's deteriorating and why, make her feel again sad and all. So this might happen. So you leave it there. But there might be scenarios in which the caregivers don't want to say, but the patient might be wanting to know. There might be a patient who says that, I want to know about my condition. See, the patient has every right to know about their condition. It's always from a patient's perspective. It's always important that the patient's wishes and rights are taken care of. So what we do is that if the patient says that, I want to know about my condition, we go back to our caregivers again and say that, see, the patient has some idea of what is happening to her, and she is asking for information. And from our part, it is our duty to communicate the information. It's their right to know about their information. We again come back to the caregivers, maybe make them understand. They take their consent and we go back to the patient and tell. We had this caregiver. The patient was around 85 years old. The son was around 65, 60 or something like that. And the son did not give us a consent till the last moment to communicate with the mother. And the mother, she did not even know that she had cancer because the son kept on saying that she was having a random stomach pain. He did not give us consent. He was very what you said, adamant about it. Please don't tell to my mother. So in cases like that, we cannot force information into them, right? If we force information and if something happens to the mother, we might be responsible. But if the patient asks you, see, I want to know about my condition, then you have every right to communicate. But make sure that you come back to the caregivers and take their consent again. The patient is asking for the information, so I am in a position to tell them, right? So this is regarding communicating bad news and spice protocol. Setting up perception, we give a warning shot, we invite knowledge, facts are given, emotions are dealt, we give space for them to vent out, and then we plan the further things. Moving on, our next topic is collusion. So collusion is any piece of information about diagnosis, recurrence, prognosis, which is withheld from the significant person. For example, we withheld this information. And most of the time, collusion happens as an act of love. Because see, I don't want to hurt my mother. I don't want to, make her more sad. She's anyway suffering. I don't want to make the suffering more. So most of the time, collusion happens as an act of love in order to protect the patient. So information, significant information is withheld from the significant persons. Okay. Information about diagnosis, recurrence, and prognosis in the advanced terminal stage of disease, and medical details about the deceased person is being withheld from the significant persons is known as collusion. It can happen between professionals and relatives. It can happen between relatives and patients, and it can also happen between relatives and relatives. And most basic reasons for collusion is good intentions. For example, I was mentioning this. We had this case. I'll explain this case. Okay. So we had this girl who was 23 years old with osteosarcoma in pelvis. Hemipelvectomy was done and she was okay. She was doing fine. This was done on the right leg, and she was okay with it. And later on, she started having pain on her left leg as well. So that's when she was referred to RCC, and from RCC, it was known that she had it has spread throughout, and she had multiple metastases and all. The parents knew this information, but they kept this information from the girl. And the girl, when she came to Palliative, she had severe pain on her hip area and her legs, and she was on morphine and all. She was given medications for pain management, and everything was done. But during the first admission, she used to sit and do the craft, DIYs, paper craft and all. After a while, she went back home and she came back again for admission. And at that time, she was completely bedbound because even a slight movement around her hip area would cause tremendous pain for her. So she had pain completely over her left leg also. She kept on asking why I have pain over my left leg. We spoke with the parents, so we communicated bad news with the parents. They were okay, they were willing, they were accepting, but they did not give us consent to tell the same with the patient, with the girl. They did not give us the consent to communicate bad news with the girl. What happened was that after later on, she had the sleeplessness was there. She had tremendous pain, and she felt her mother was not loving her enough because she was not taking care of her. And the family kept on saying that, once your pain comes down, we can go back to RCC and take chemotherapy or radiotherapy, whatever. But your pain has to come down before that. This was what was being kept on being said to her. So what happened? She started having aggressive outbursts, anger outbursts, especially towards the mother. She was very rude to her mother. She was very I used to take counseling sessions for. She's kept on saying that, my mother doesn't like me. They're not doing enough for me. She had all these doubts, and she started having some hatredness towards her mother. That's when we again sat with the caregivers. We said it is very important that the patient knows about her condition. That's when they gave us consent, and they said they are not in a position to convey the news to her. The team can do. So the physician that was treating her, our palliative physician was there, myself was there. We communicated bad news to her. The session around took 1 hour. Uh, During the session, she gave us consent. We gave warning shots. She said she wants to know, and that's how when we communicated completely regarding the progressive nature and the deteriorating condition and all. She, tears started welling up. She started crying, but she did not speak anything. What happened? After communicating bad things with her for the next 3 days, she did not talk to her parents completely. I used to take sessions during this time. She did not talk to her parents, and I had a conversation regarding why you're not talking to her parents and all. You know what she said? She used to call me Chichi, okay, sister in Malayalam. She said, you know what? Uh, why did they lie to me? Why did they lie to me? Why did they kept on, why did they keep on saying that, I'm going to get better? This condition is going to better, and that I still have treatment options, and all. Why did they lie to me? She was having those pain because, her parents had supplied to her. So she did not talk to 3 days. Complete numbness was there from her side. But after 3 days, her anger came down, her aggression came down. She started talking to her parents, and everything seemed more comfortable because she was more accepting towards the fact that, this is how things are going to be. The anger towards her mother also came down. So, something bad is happening to our body. We know that for sure that, something is not right. But people around me are saying that, you're going to get better. It's not something that you think. There is this conflict that builds inside me, right? So this is going to create a lot of conflict, lot of ambiguity, lot of uncertainty, and this is going to come out as anger. I know if something bad is happening with my body, I'm very sure to know, right? So, something is not right. Something is not right, like the others are saying. But Here, the people around me are saying that you're going to get better, you're feeling much better, but I'm not feeling so. So this conflict is going to come up as anger. So it's always necessary that you communicate properly. So most of the time it is done with good intention, love and to protect for emotional and psychology. See, I don't want my wife to go through this, and so I don't want my daughter to, go through such suffering and all. What if I communicate bad news and they may give up and die if I told the truth? So these are the concerns that they might have, why they are having collusion, believe that the patient may not be able to cope with the truth and all. Property issues might be other reasons, concerns about causing trauma to relatives, for example, old. Social stigma could be other thing. For example, there are still stigma around cancer. There are still stigma around having AIDS, right? So these social stigma might be a reason for collusion. Ignorance and lack of awareness also is other reasons for collusion. What happens if collusion is there? Honest communication is hampered, elevated emotional and psychological distress, isolation, anger, guilt, frustration, loss of trust, just like how it happened with this girl. Unfinished business might be there. Conspiracy of silence. See, everybody is suffering, but they are suffering alone. We want to bring them together. If collusion is there, everybody is suffering, but they are. And constant stress and burden of hiding the truth. See, I'm continuously hiding the truth, and this stress and burden is also there from the caregiver's part. Inability to eat, sleep, and communicate with others. Patients feel out of control and trapped. Uh, this is another example that I usually do with patients. See, for example, Amrita is a 65-year-old. She has been diagnosed with CE ovary. Sanjay is her son and he has come to meet you. He appears confused and restless. He do not want to reveal the diagnosis to his mother. How will you handle Sanjay? Sanjay's mother is having CE ovary. Sanjay is not ready to, he is not ready, willing to even say the diagnosis to his mother. How will you handle Sanjay? Can I see a few responses in the chat box? Any responses? How are you going to tackle Sanjay? Question this. Sure, sure, sure. Yes. What will be the first step? A few responses. Try to find out why he's confused. Thank you so much, and that's the most important thing that we have to do. Thank you. Right. So you try to explore the reasons why he is not willing to communicate, right? Why doesn't he want to reveal? What is holding him back? Is it the fear that his mother might give up? Is it the fear that's of something else? So we need to address those fears and actually explore the reasons of solution, why it is so, and then address each concerns. If it's the fear of what if my mother completely gives up, what if she won't take the treatment, you have to sit with them, understand what the reason is and address each of the reasons. We had another case where the husband was not willing to communicate the deteriorating condition to his wife. And you know what? In the later days, what we saw is that she felt the husband was not doing enough. The husband was not caring or loving her enough. The husband did not want her alive. That's why he was not doing curative aspect. And that's why she was in palliative care. She had multiple thoughts. And finally, he gave us consent to communicate bad news with the patient, and we communicated bad news with the patient. Even then she was in this idea that I need to take one last opinion from my treating doctor who was there at KIMS for the curative, if at all curative aspect is possible. And then we again stressed See, it would be very difficult at this point for you to have a very long travel and all at this condition. But if it's very necessary, we'll arrange the transportation and we arranged an ambulance. She was taken to Kim's, and her treating doctor also said that you have to continue with palliative care, and that's when she was released. So always make sure that we give importance to what the patient wants. Right? It's not necessary that they follow what we are saying. So moving on, acknowledge collusion, explore reasons with the relatives concerned, elicit worries and questions, feedback to the relatives, explain to the relative why it is important, the importance of reassurance and honesty, why it is important that they know about their conditions, encourage dialogue between the patient and the relative. If they cannot do it, you can do it. Also take consent. Value statements by family members. We cannot force information into patient or caregivers. We always have to value what the statements of the family members. Acknowledge family members' emotions, listen to family members, understand who the patient is, elicit questions from the family. See, at the end, did I listen? Did I explore their beliefs? Did I make an acceptable working condition? Did I share options? Did I share in decision making, etc.? Did I develop a good relationship? Have a retrospective thought. Did I do it? Take home messages. See, communicating bad news and pollution, everything is mostly best learned through experience. Identify our skills and try to refine them. There is no fixed guidelines. See, this is the universal way in which it is usually done with SPICE protocol. You have to try to impart this in our own setting so that you learn through experience and all. Should be patient-centered and context and culture-centered. It has to be very culture-centered, I would say. Accept limits. There is no role model, never assume. With that, I come to the end of my session. And I'm open to take few queries, questions, any personal questions that you have from your personal experiences or from clinics. I'm good to doubts, queries. You can also use the chat box. Spend more time with him and explain to him the importance. Thank you so much. Right. Thank you. Questions, queries?
Dear participants, kindly ask your doubts.
You can also ask in the group, okay? If after the session, if you're having any doubts, please make sure that you put up in the group so that it will be dealt with, it will be answered, right? Thank you so much for being interactive. Thank you so much. Hannah, can you please
Yes,
take
ma'am.
over?
So I hope the session was clear. You can share the feedback also. Dear participants, kindly respond. From next time, you have to take the sessions. Yeah, they are saying excellent presentation, ma'am. Thank you.
Thank you so much.
Thank you,
Thank you.
Pramila. Okay, so I think we can wind up the session, ma'am. So thank you, ma'am. Thank you for the insightful session, and please share the PPT with me so that I can share with the participants. Thank you, ma'am. Thank you for your
Thank
time
you all.
also.
Thank you so much.
Yeah.
Thank you.
Thank you, ma'am.